again observed by Dr. Okello, the current one that we are dealing with, the Delta, is more transmissible. It catches faster compared to the others before it. It can even catch people who have suffered from COVID before, and including even those who have been vaccinated, although the outcomes are much better when one has been vaccinated before getting this.
Okay, Dr. Msoke, when I look onto the dashboard here, I see that the cases in Sierra Leone are not as those that we have in Uganda. And we know that Sierra Leone has just come from that history of also battling with Ebola. Which of course ravaged them more than it did to Uganda and maybe the other countries. And strangely, Sierra Leone is one of the countries on the continent that got their COVID cases much later than almost everybody. What are they doing right that is helping them this time round that maybe we in Uganda and the rest of Africa can also copy from that other African country in Sierra Leone?
Yeah, thank you, Mr. Jagenda. So Sierra Leone is different from Uganda in many contexts. In terms of population, here we are talking of about 7.5 million. Uganda, we are talking of close to 40 million or thereabout. So it is a different situation altogether. But also in terms of population distribution and the population movements, here we have a little bit of a more urbanized population. So we are seeing most of the cases around the capital city where there is more population density around, and interaction between the capital city and the provinces in terms of population distribution and travel in between might not be as much as it is in Uganda. But true, the country is also doing a number of interventions which may not be similar to what is being back home. For example, currently Uganda is in a total lockdown. This is, I think now we are in the second week running. But in Sierra Leone, we don't have a lockdown as such at this point in time. But there are a number of other measures being done. In terms of vaccination, the picture is more or less the same. We are having very few of our people vaccinated so far, and maybe we shall get to that at some point during the discussion.
Okay. Well, thank you so much, Dr. Msoke, for giving us what is actually happening in Sierra Leone. We'll come back to studios, but we thank you that you're still with us online. Let's get back to your fellow Dr. Okello here in studios. Also speak to us. Then, if you feel you have anything to chip in, Dr. Msoke, please just raise your hand and come in, and let's hear your thoughts on what is happening. But we're happy to have you from Sierra Leone, where you are right now, and thank you for having allowed us to inconvenience you very early in the morning. To us, it's already into the day of business. To you there, it's still very early. Dr. Yen, you've heard from Dr. Msoke in Sierra Leone, and of course, he's tried to also share the figures with us here. But there's also the politics of vaccination, where we actually have lots of issues coming on. One of the other things that we have on the continent, we talk about a continent or a population that is very, actually we're not even vaccinated, we could say. 1% is not anywhere. But the problem is what we tag to the vaccination itself and how we look at it, how we view it, and a number of things that we're saying. We don't seem like we really want to be vaccinated because of the politics of the vaccines itself, and we do not know what it is. What is happening in Uganda currently is that people are saying that those that have actually received the jabs are the ones who are even dying, and that is also scaring people away from going for vaccination. And we're talking about an unvaccinated population and how it's managing the variant.
Yeah. Let me start with the last one. Dr. Msoke, welcome, and I'm glad he's here with me. There's a term we use in public health, what we call vaccine hesitancy. And that has been there, even when you were giving childhood vaccines. You'd find there would be mothers who would say, my child is not going to be vaccinated. The father would say, my child is not going to be vaccinated. And each time we would have discussions with them, you'd find that all this came more from association. As you say, you associate something, but it is not the direct cause. You know, they would say that, you know, when Mr. Jagenda comes every Tuesday at 9, it rains in UBC. Now, that may be an association, but there is no cause that Mr. Jagenda actually brings rain each time he comes. So most people, what we are seeing now is that people actually say, oh, such and such a person was vaccinated and such a person died. What we have seen and what we have seen in other countries, and I tell them that we were lucky as Africa that right from the beginning we saw what happened in other places. We saw how the cases, but we kept on that message that
by the time you finish explaining today, we would have lost 3, 4, 5 people. So the rate at which the infection is also running is fast. So I think there is a need now to come in with a number of interceptions, including information, but also the health community is also very busy. You remember, yesterday we have been running around to get some of the professionals, and we are lucky.
Lucky to get Dr.
Kavanda, who was also trying to run around to find someone. But you realize that most of our professionals are of certain facts. So, of vaccines, because these vaccines are made by companies, and these companies are not religious organizations, but even religious organizations, you now know, they are looking for money. So there has also been that politics. This one doesn't work. This one works this way. This one works this way. But also for Africa, like the president put last time, I think we're also unfortunate. We have professionals. We can also have our own vaccines. But like Africa has not given that chance, or has not also taken that initiative to ensure that we have our own vaccines. But even when we try, we're now having issues with Covidex, because people are saying, those who have, but now the other agencies, the other companies, the others are saying no. This vaccine needs to be taken through all the protocols are supposed to, which is true, because you cannot get all the necessary procedures. But this is a dire situation. Do we wait until that all of those are done? But even the vaccines, you remember, doctor will tell you that a vaccine to be done, it takes a number of years. But we may not even wait to see all those years when the population is in dire need. Now, the other thing is the exact politics, the political sentiments. We have seen countries in Africa, we are talking about the large part of Africa, where vaccines have been refused. And we have seen populations that have not even allowed in the vaccination. And also have seen countries where vaccination is optional. But if you're having a population of only 1% of people are vaccinated, and you have all these other issues now, where does that leave Africa? At the same time, like the president said, we are only begging people, because doctor told you, even when with money, you may fail to get it. So it is like, because even those who are producing the vaccines also have problems back at home. I've seen from India, which is one of the countries which produce most of the vaccines. But they are stuck.
Okay.
When they were struck, they also had issues.
We're seeing so many vaccines on market. There is AstraZeneca, which is, I think, very predominant. Quite a number of these, and there are quite a number. And we do not know which is more effective. We do not know which we should prefer against all the others. But according to the experts, you actually seem to tell us, or to convince us, that all these vaccines are the same. But yet again, we have this stereotype over the vaccines. And we're talking about the vaccine itself. If we know that it is a vaccination that is going to help us fight the phases or the waves in which we are enduring now, and we have issues with the vaccines, I don't know what is happening in Sierra Leone. I don't know how they're receiving this. I don't know what they're doing with the vaccines. But let's talk about the vaccines themselves and what we think we need to do as a continent to overcome this problem.
Thank you, Mr. Simakula. It's unfortunate you're asking me to talk about politics.
It's a part of life.
So anyway, I can say some. If you look at the global statistics, you see that countries that have vaccinated a lot of their people, things have started. I would probably call it challenges related to financing and from the start. And there are some global facilities that were put in place to mitigate against some of the anticipated challenges. There's what we call the COVAX facility. Facilities to enable countries to get vaccines through one basket, as opposed to countries
in Sierra Leone.
Well, I would say it's the same across the continent, what we are seeing, but it's not even just an African problem. It is a public health problem and it is a global problem. And it is not just for the for COVID-19. What makes it now more complicated is that we are dealing with a new disease that is rapidly evolving. The science of it is still also being it's a situation that is on a pandemic scale. We haven't been dealing with problems like this before, but all kinds of vaccines that have been developed before have really gone through the same kind of process. People have to scrutinize information back and forth to finally believe that actually this is going to protect. And many times, we have been having these discussions with some of my colleagues. In the beginning, when COVID started on the African continent, like South Africa, not so many people were dying. And some people believed maybe Africans are immune to this problem. Maybe we shall not see deaths. So maybe we also don't need vaccines. But now we are seeing that actually deaths are taking place, and we wouldn't wish for us to only understand because we are seeing a death, but unfortunately, many times we take COVID seriously, and we need to promote the use of vaccines when available. At least at a personal level, what I told those who are close to me, I encouraged everyone to take the vaccine and ask questions later, because there wasn't just enough time to explain. So that is the approach I used at a personal level. But I would encourage everyone to promote vaccines when available, and to those who deserve to get them. Thank you.
Okay. Well, we thank you, Dr. Msoke. We're still with you for the next 1 hour. We'll just take a break now. And when we return from the break, we'll continue the discussion. And we thank you so much for being with us live in Sierra Leone, where you are. We'll take a break and...
Good Morning Uganda Extra. There's magic in sharing the things that we learn, because it's those things that bring us close together. What does it mean to be closer together? It's taking the last bus home for a surprise visit. Closer together is strangers finding a connection. It's bringing home something much more than a box. It's the warmth of home, or the beginning of something new. There's magic in sharing the things that we learn, because it's those things that bring us close together.
Uganda has the best and most affordable rates when it comes to withdrawing and sending money. Withdraw money for as low as 330 shillings up to a maximum of 12,500 shillings. Sending money is just as affordable as ever. Absolutely unbeatable. Use Airtel Money on the most affordable network with the largest network of Airtel Money branches in Uganda. Dial *185# to get started. Airtel Money. Simple, secure, borderless.
Live from UBC Studios in Kampala, this is Good Morning Uganda Extra.
Pan-African Friday, my name is Uganda Semakola Zuksoka. Welcome back to UBC TV. Continuing with the conversation here, discussing the variant, the Delta variant, and asking a question of how we think our content should respond. Being unvaccinated and thinking that, or having known that vaccines are the way to go. We have in studios Dr. Okello Ayen from Kampala Capital City Authority, and of course he's one of these, one of the people that have been on the front line fighting this pandemic from when it broke out in this country in March last year. And we also have Dr. Robert Musoke Ntate joining us live on Zoom from Sierra Leone. He's a Ugandan expert, one of those who were deployed in West Africa to go and fight the Ebola epidemic that had broken out in the countries of Sierra Leone and Liberia. And he's also talking to us from where he is, and which is very commendable of him. And of course, Akol, before we get back to Sierra Leone, before we come to Dr. Yen.
Dr. Yen had talked about the issue of information. Yeah, and I just want to begin on that because there was a lot of negative information. Which are negative publicity.
Infodemic.
Look here, they are dying in thousands. Why do they want to test the vaccine instance where people are really hesitant, saying why, but about that we need to come up with an African solution. Perhaps maybe if the team of doctors on the continent, the CDC, perhaps if they announce that, look here, this is an African vaccine, I believe most people on the continent would have more faith in the vaccine, because some people are saying, like, look here, now somebody manufactures a disease for you, again, should not be the same person really to send you the vaccine. Of course, those are some of the sentiments. So we have a feeling that really our team of doctors really on the continent, this time around, the Africans are really shifting from seeking divine intervention. Now this time we are still focusing on the human intervention, our experts intervention. Some interventions when people say maybe the gods are angry with us, but now we are in this particular thing. But again, coming back to really to Dr. here and also Dr. COVID, and perhaps what lessons we can learn from, because Sierra Leone and Liberia were hit seriously.
How they fought Ebola, you say?
How they fought, yes, how they fought Ebola, yes. So how they can paint a picture, and perhaps how can we use that particular experience in fighting this. Now, back to Doctor here. I just want us to look at you as people in the medical field. How are you advising government? Because
just start on how we're advising government on the health market, the dynamics of the health market, and whether government should intervene in the health market or no. By nature, our health system, the way it is designed, as I say, it is a dichotomy. There is a public and there is a private. Now, for the public, services are free. And by having that nature is that we are already indirectly intervening in the health market. And when the COVID-19 pandemic started, the first thing government did was, we are going to offer these services at no cost. So when the treatment centers were opened, the point was, let's offer it at no cost, such that if it is at no cost, whoever would want to come in, we have already set a level that there is an alternative. Now, once you have an alternative, then you tend to intervene in the cost that the market may then be able to offer. Now, the challenges that what COVID brings is that when COVID starts overwhelming or putting strains in that service that is at no cost, you'll find alternatives will come in. Now, these alternatives that will be private in nature would then probably have costs that may be much, much higher. Some may be justified, some may not be justified. Now, the other thing is, let government also, how does government intervene in this area where you find that the costs may be a little bit higher? And that is why at that point the Ministry of Health, I'm aware, has had meetings with the private sector, and also other arms of government have had meetings with the private sector, such that those costs can be brought to a manageable. As you're saying, the principle is, it is a pandemic. Secondly is, let us have the principle of saving life. The issue of costs and the issue of profit, as the President has always said, can come later. If you're looking at these people, persons or patients as your customers, serve the customer first as a principle. The customer is always king. So if you feel that you're not making the customer as king and making him go closer to his grave, then the customer is no longer king. That means you're not serving the principle that you are. That's why it's saying life first, then the issues of profit can then be able to come later. And I know the Honorable Minister is going to make a statement
today. Sometime this afternoon.
He's going to make in Uganda. He's going to make a statement this afternoon. And I know those interventions are going to come in on how we can stabilize the market and probably reduce on these unfair costs that are being put on different people.
Dr. Msoke, I call us to a question on the pandemic the epidemic that you had of Ebola, and maybe Sierra Leone learned some very good lessons, because it's not long ago since we saw that outbreak of Ebola in Sierra Leone. To know whether Ebola came with very good lessons that Sierra Leone is using to manage COVID-19.
Take to it. So the outbreak of Ebola in West Africa 2014 to 2016 affected mostly Sierra Leone, Liberia, and Guinea. And a number of interventions, public health interventions, were used to overcome the outbreak. Most of them were not really new interventions, because they had been tried and tested elsewhere in the world, and these are the ones that were used here, with a few modifications to fit the local context. But the addition I wanted to make is the role of vaccines, because as we may be aware, there has been another outbreak of EVD in Guinea earlier this year, starting around 14th of February, and the outbreak was declared over on the 19th of June. But the most recent outbreak, which happened just in the neighborhood to Sierra Leone, was much different from the one of 2014-2016, and we believe the difference has been mostly attributable to the vaccination. This most recent outbreak involved 23 cases and about 12 deaths. Unfortunately, about 5 health workers died during this most recent outbreak, but also a lot of individuals, including frontline health workers, were reached out with a vaccine. Over 14,000 cumulatively, and we believe because of this, we did not see this outbreak explode out of control, no exportation of cases to neighboring countries, and no even exportation of cases to other regions of the country, apart from where the outbreak was reported. So I trust that the vaccines really helped a lot. But through the fact that the country here had gone through the EVD outbreak, the coordination structures that were used back then, the leaders and the technical personnel who are involved in the EVD outbreak has really helped a lot in designing interventions around the response to COVID-19. this time round. Thank you.
Okay, well, thank you, Dr. Msoke. Dr. Yen, let's look at the biggest contributors to Africa's statistics of COVID, because you've all talked about, you called it actually infodemic or infodemics or whatever that is. When COVID got onto the continent of Africa on a Valentine's Day last year through, I think, Alexandria in Egypt, they vulgarized it and took it as an everyday flu or whatever that was. It crept to South Africa and several other countries that were hit so hard in the first wave, and they just looked at it and played about it. We tried to manage it in the first time because we were dealing with something unknown to us, and but when it gets to where we are now, I think we have the media seems to be losing it. It just seems out there that Musoke is in Sierra Leone. But he, of course, knows what is happening. We're living in a global world. But what is coming to the media or through the media seems to be very worrying that now Uganda seems to be the next epicenter of Africa when we talk about the Delta variant here. Are we the biggest contributor to Africa's statistics of COVID currently?
When you look at the countries, I think the week, and Dr. Msoke will chip in later. When you look at the week, I think 21st, 20th, Uganda is of last month. Uganda is among the top 5 or top 6. I know it's South Africa, Zambia, Namibia, then Rwanda and Uganda. So we are among the top 5. In the other weeks, we have actually been within the top 5 contributors of the countries contributing in Africa. South Africa is way above there. So yes, in terms of us being among the contributors, yes we are, because we're in the top 5, and this has been reflected in some of the international response. You can see, I think the UK put us on the watch list, and I think apart from residents, Ugandans are not allowed to get into the UK. Dubai also put us on their watch list, yes. Whereby I know their airline, national airline, no longer flies there. It has been suspended. So that's how we are being looked at internationally. Yes, we're a contributor, but reducing, but we are still among the top 5. So yes, we are.
Okay. I don't know whether I'm trying to answer something, but Dr. Msoke, on the statistics therein, as Dr. Ayen is talking about it here. Chip in and let's hear from you.
I beg your pardon. Is it possible to rephrase for me?
Oh, sorry about that. We talk about the statistics, and Uganda being one of the top 5 African countries contributing to Africa's statistics of COVID-19. And we were hailed as one of the countries that had actually managed the COVID pandemic. We actually hailed up there as one of the best countries in the world. Now it is stunned. We are now one of, I don't want to say one of the last, now the best again in contributing to the infections. What do you think explains this, and how can we run away from this?
Well, it is probably the nature of disease that we are dealing with. It's not that when we have a lot of cases, then we have failed. The disease itself has been, many of the countries around the world have experienced these waves before. And what we are experiencing currently is a wave. Naturally, it will slow down. The right things are being done. The public health and social interventions going on at this point in the country. The fact that now there is restriction on movement and travel within the country, and people being limited to their communities, possibly is going to help. And by the end of the 42 days, we shall have less COVID. But even then, it does not necessarily mean that we shall not get that is more transmissible. We have just had this again this morning. The Delta variant is a lot more transmissible than the others that we were having before it. So it's the nature of disease that we should probably focus on, and not the capacity of the country and tagging that capacity to the numbers that we are seeing, because different countries have different contexts. And what remains constant is the disease itself.
Gentlemen.
Now, Maybe for the case of Uganda, like Dr. M has been putting it, has been a lot to do with the interaction, where we have the populations and the movement. But Dr. Msoko was telling us that in Sierra Leone, of course, population is still low, but the spread among the urban population is still high. Now, I also wanted to find out how the people in Sierra Leone are adhering to the SOPs in the country. Maybe it is part of the reason as to why the transmission is not
as high as it is
high as it is much as the population, because we even have countries with smaller populations than Uganda, but still we have seen
high infection rates.
High infection rates. Is it possible that it is the people in Sierra Leone are adhering more to the SOPs?
Okay, Dr. Msoke, answer that.
I can come in and mention a word or two about that. So adherence to from time to time, and it varies with the perceived danger, but also the on the enforcement of the same. So in the last few months, we were having very few cases in the country. We were reporting less than 10 cases for many of the weeks between around end of February to about end of May. So the country was really at peace in as far as COVID-19 was concerned. Then all of a sudden, cases have increased. So now there is a lot more focus on adherence to these SOPs, as we call them, the social distancing, the hand washing, the use of masks in public spaces. Now there are a lot more, it is like the police are now more concerned about it. But again, it is something that we have also been seeing in other countries, and even Uganda is not an exception. But what is important, I think, in moving forward is keeping the adherence to the SOPs for some time moving forward, even when the perceived danger is low.
Okay, Dr. Msoke, I want to ask Dr. Yen a question, which you two will respond to after Dr. Yen has submitted. Dr. Yen, in April last year, you scientists came out with a model, and in that particular model, you anticipated or projected that 18,000 new infections in only the month of April 2020, had we not gone for that lockdown, and 3% of those amount of time, World Health Organization had told us or briefed us on how COVID was moving around the continent, of course, the world. One, you had what you called the cases, the index case. Then you also had what they called the community spreading. You come into the community spread, then the community transmissions, and eventually we would see maybe people dying. But there's a scientific model that you, the scientists, put up. Do we have a specific model that is helping us fight this particular Delta variant? And Dr. Msoke, I would also love to hear from you whether the scientists in Sierra Leone have also had a model. They've also got their own model, which is informing them on the help the people in there. Dr. Yen.
Around April, we are seeing that for every positive case, we are now getting between 23 to 30 interactions for each case. Now, about the same time last year, people were being a little bit hesitant when we first heard about the COVID-19. People started self-regulating themselves. Now, in June, July, when we started opening up, and people probably thought that, oh, as Dr. Msoke said, the risk perception started going lower. Then the interactions became more. And when the Delta variants came in, and those interactions then were much higher, then it was these are the interactions that are there and the risk profiles. We have also seen a model, and these models also look at the country's capacity. How many ICU beds do you have? What is your capacity in case management? Such that even if I went to critical severe, is there the capacity for the health system to be able to take care of me? And that is why at some point we'll advise, people call them lockdowns, but we call them non-pharmaceutical interventions. It is not medicine, but it's something that's a way for you to restrict certain sectors. And basically what we are saying, let us reduce the interactions between individuals such that the spread then becomes less, and by having less people getting it, then you have less risk of people going to severe and then affecting your health system. So again, yes, the models are there that inform us, and that is how we inform and say, you know what, you need to up your ICU capacity, you need to up your high dependency unit capacity. We need to be able to restrict this sector because this sector is a contributor. And if you remember, that is where we say now for schools, we need to do this for schools to be able to operate. So those tend to contribute. Look at the high risk areas, and then certain decisions are made that how, if they are to operate, they can operate within a certain mode, in a certain mechanism. Now that mechanism which they operate is what then informs you having the standard operating procedures. So that is where the term of standard operating procedures then does come along.
Dr. Msoke, talk to us about the modeling in Sierra Leone.
Apologies, at this point in time I'm not really up to terms with where we stand in terms of predictions and the modeling is. We had it in the beginning, that was around March, April 2020. We sat down and anticipated the number of people that we anticipated would fall sick, and the number of severe cases that we would get, and therefore prediction on bed space and the ICUs that would be required. We had that discussion. But as the pandemic has evolved, and with different interventions coming into play and different factors, we have I can cross-check if we have any predictions at this point in time, but I haven't been in any discussions at this moment on the same.
Okay, and let's talk about government's preparedness in Sierra Leone to actually manage this the pandemic itself. We're looking at the health facilities. Now we know that all our health facilities on the continent are actually overwhelmed and overstretched because of what we're seeing. When you come to Uganda, for example, the Uganda that you know, that you've lived in, that you've grown in, before the lockdown last year, we didn't have the capacity that we have now. But even then, the capacity that we tried to build still is overwhelmed and overstretched because of what is happening to us. And we can't promise that even if we built hospitals today, then we'll be able to possibly manage all cases in this way. What is the situation in health facilities in Sierra Leone, for example?
So far the situation is still under control, apart from capacity, but some are still available. So what the country is doing, in the beginning of the pandemic, there was mapping of the existing facilities and where cases would be managed. Health workers were trained at specialist level, but also at operational level to offer the treatment that is needed. There are some specialized facilities as well within, especially the capital city. So the bed space and the facilities and the health workforce is reviewed from time to time based on the problem at hand. A few months ago, when the burden had gone, some of the additional health workers that had been put were being brought back on board, because we are now dealing with a bigger problem than compared to a few months ago. So this is the approach that we are using around here.
Okay, thank you very much, Doctor.
Doctor, there was something also. We part of the problem that Africa is having, and we're hearing this from the friends and others of Africa who would want to give them some of the support, is the manpower. He's talking about the personnel. Now, one of the biggest problems that these people are saying, had this morning, so I think it was on BBC or some other station, that part of the problem of Africa is the
human resource.
yes,
the workforce.
because
yes, and
we
have
have countries which have been given because it's talking about CUs that have been given ventilators, but we don't even have people who know how to use these ventilators. And then we have the facilities, some of them, but we cannot be able to use them. Even the vaccines themselves, they are health workers, well, but they are not trained on how to handle these vaccines and how to handle people. Because we also have had people who say, maybe by the time I was vaccinated, I had other problems. That is why I'm having some of these reactions. So how is that being managed the other side? But also, Dr. Ayam will also tell us, as a country, how prepared are we also?
Dr. Msoke, on the issue of frontline workers and their capacity, the human resource now at the forefront of this pandemic.
Well, I don't think I can be specific countries at different levels, but we certainly have gaps. At least here in locally where I am, what was done in the beginning, some specialists were identified and they were trained on COVID-19 case management, and these have been training others over time as the pandemic moves on. So where we are standing currently, most of the district hospitals, most of the big health facilities have focal points who have been trained on most of the aspects. And as the pandemic moves on, I can say here it's not really absolute lack of capacity, but relative lack of capacity when the problem gets out of hand.
Okay. Thank you very much.
Yeah. I was also wondering to find that from our own experience back at home.
Yeah, and again, I'll pick from Dr. Msoke. The area of critical care has been one where we had not had that capacity as it should be, because again, you see that in areas that have developed critical care systems, the critical care systems are developed usually to deal with trauma, and these were in cities where there are either shootings, there are accidents, you have good roads, people speed. Now here we didn't have that level of critical care, because initially most of our diseases tend to be communicable diseases.
Exactly.
Brought out a totally different area to it. And 1 year ago, when you look at the critical care nurses, when you look at the people who are in ICU, the numbers were quite low. But with time, the capacity has been built. I know right from the medical schools, right from the trainings, right from the mentorships that Dr. Msoke said. And you could say, because Uganda had the experience of also having Ebola, having Marburg, some of the measures, especially infection prevention and control, seem to mirror what was in COVID. So we had a pool of people who had dealt with this, who had dealt with Ebola, who had dealt with Marburg, and now the issue was the case treatment, which again we have trained people. And I know we are continuously recruiting. But interestingly, even the countries that had more advanced health systems, one of the things they did was to forego some of the restrictions. So they, at one point, I think the UK and America said that we have actually foregone some of the restrictions for foreign medical workers to come into this country. So they kind of made it easy for that. And what I'm trying to say that this was not something that is unique to Africa, but they also felt the stretching within those countries with more advanced system. And that is unique of, that's the thing with COVID, is that it will affect so many people at the same time. And even no matter how advanced your health system is, you find that you won't adequately respond. But for us as a country, and I'll give the example, last year, as regards testing, not many of us know. Probably we knew the only places you test was the Central Public Health Laboratory and Virus Institute. 1 year later, we have about more than 30
testing centers.
Yeah, testing centers that are all over doing PCR. And again, all the regional referral hospitals were made into COVID treatment units right from Lagos. So the capacity is being built, and to me it's an opportunity for us to then be able to up our critical care. And as I said, in some of these cases, we use it to then build the capacity of the health system to respond to any other outbreak that may come. As Dr. Msoke said, we don't know whether there's definitely going to be another wave, so we need to prepare.
Okay.
But again, before he comes in, Doctor has talked about something which is also very cardinal, especially now, because we are seeing that most of the victims of COVID are either people who have delayed or delayed to know their status, such that by the time you begin treating malaria,
when it's late.
So by the time you come to actual treatment, sometimes it's too late and the health team cannot reverse. How are we handling this, especially in Kampala now? How easy is it for a person outside
to access,
to access this testing in Kampala?
On time, to know before they actually get there when it's late.
Exactly.
One of the things we have done, and we have been working with the Ministry of Health, is to adopt a new testing methodology. Before to test, you needed PCR, which is expensive. Now the country approved the rapid testing kits. Take out the same time like if you want to do an HIV test.
The rapid antigens or something?
Yes, rapid antigen testing kits. So with the Ministry of Health, we have been going to the communities. I know the other day we were in Owino Market, the other day we were in these areas, and we are going to expand out such that people can be able to know their results much easier, and it is at no cost. We know that testing is one way of risk communication, because if you know your status, then you can be able to
withdraw from the public
to adopt your behavior accordingly. So that is one thing we have done, and it is now ongoing. And again, it's out of the innovations whereby we are realizing that the rapid antigen testing kits, when they are giving us quite accurate results, and that is one way we can be able to also improve on getting people to know. The other is COVID is a very testing disease, and you'll get people who in the morning they seem to be okay, and what we say desaturating, the oxygen levels in their blood fall so rapidly that even by the time you respond to this person is in such a severe form that then you need to have certain critical measures to respond. Those we are getting at home when they actually do respond, and they'll tell people that it is what they call happy hypoxia. You don't have oxygen, and even trying to resuscitate you becomes a problem. So that is again the nature of the disease.
Akol, you wanted to ask something?
Yes, no, I just wanted to contribute something, but as well as also ask, because as I had mentioned earlier, that Uganda has been among the top 5, at least maybe for the last 1 month. But I also think that that goes back to our behavior, where we are turning into a Nyangao society, a Haina society, where we just want to take advantage of everything, because they just want to look at the transport sector. When they allowed for the transport sector to reopen at half capacity, some would actually load full capacity and overcharge. And I think that is how the variant, that's how actually the numbers will must. But also the other issue is also abdicating our responsibility, is whereby we became so complacent, say no, I think now we have a success story, we've really managed it, and definite situations, if we also don't check our behavior, then we may go back. But also the other issue that I also wish a doctor to talk about, because this is non-medical, because COVID is both a social and economic hazard, and whereby most organizations have actually been told to downsize up to 10%, implying that most of the people really have to work home. So what is government doing so that really to make the environment suitable for people to work at home? Because in some, when you look at electricity, in other words, what percentage of the country really has electricity? Water supply, because we've been told that the National Water and Storage Corporation, in some areas, they are disconnecting people. So in other words, what is government doing so that it can make it easier for people really to work at home? Yes, I think that is one way we can really fight COVID-19.
Yeah, you brought out the aspect of the societal disruption. How do we adapt to societal disruption? And there are many ways of adapting to it. And when we have been dealing with people in the workplaces, we have been advising them on certain things to do. When you look at the banks, one thing the banks have done is that, yes, you need to walk, they have what they call the agents. So do you need to walk into a banking hall, or do you need to go to the agent? If you're a little bit, if you're sophisticated and you have internet, probably walk into the office. If you are in any other business, if I can edit from home, can I be able to get your laptop and probably say edit from home? It may be easier than you coming and sitting 4 people at a desk to be able to edit from home. Definitely bring the issues of that. For some of the work, we need certain incentives for you to be able to work. In other words, can we have more broadband across the country such that internet can move faster? Then can the costs be able to be negotiated to be able to come down? Now, I know that is something government can be able to look at, and also be able to protect the vulnerabilities that are there. So if national water be able to probably be humane at how they are dealing with people as regards this could be, and I know government is, so it should be a sector by sector response to be able to set people to see that, you know, it is not bad to work at home. It is not that we are seeing you as irrelevant, but in order for us to be able to save lives, this is what we need to be able to do. So again, as you raise the point, is that they need to be incentives such that people can feel that they don't have to come to the workplace. But we have been seen to be a country that is quite good at entrepreneurship, and I was surprised that from the markets, actually it's interesting that the guys, the border guys, are now realizing there's a lot of money in transporting cargo. I'm not sure the next time they will now want to transport a passenger if they realize that there's a lot of money in cargo. Now we are seeing the border riders now know that they can have a smartphone and be able to use. People call and make their orders from a border, he delivers to your place. So they call also in the economy of what they call the sanitizer. I think I only knew one Saraya. And most of it was imported. Right now, I don't think you have a lot of imported sanitizer on the market.
And you can't count them that are here.
Yes, and you can't actually count them. So, as the president said, those that we are making Uganda waraji, or we are making waraji, then converted into sanitizer. So there are certain areas we can substitute and say, much as this has been restricted, where can we substitute? PPEs, we believe that now there is a market for masks. How can we be able to manufacture the masks locally? So what is the adoption within us to be able to fit in what they call, in quotes, the good economy? So even if I bring down the cost of broadband, then more people can be able to go higher. So
I've had an opportunity, Dr. Yen, to interact with some of our frontline workers in CTUs, the COVID treatment units in regional hospitals. And one of the challenges embedded in there is that the numbers of the infections, or the numbers of the people they are trying to manage vis-a-vis the health workers, I think it's also not very good. In that, it seems to have worn them out the mental integrity. You know, somebody gets into that facility, they are looking at people, like you talked about the hypoxia. Somebody comes and they just really look very normal. And steadily, they drift, and the next thing is actually you're seeing people dying. And we look at these people putting on PPEs for the entire day because they're trying to manage 20, 30 people in that CTU. What needs to be done to see how to manage this? Now, that comes back to the bit of now you government and health workers to see how to increase on the workforce to be able to manage the numbers that keep surging every other day.
Actually, you've raised the more critical issue of psychosocial support. Because when a person is waking up every morning and going into PPE, your mentality has, or your mental strength has to be supported for you to be able to wake up each and every day. Now, what we have done, and with the Uganda Medical Association, is for the health workers specifically, have a different welfare channel for them. We have got persons who have developed anxiety, where they feel I cannot be able to go to the CTU. So what we advise them is, if you feel you cannot, take a week away, and then or take some time away, then you can be able to come. So we need, and it has been seen in all the COVID treatment sites, we need to be able to handle psychosocial support. And in our culture, or should I say unfortunately, when you talk about psychosocial support, people take it as a weakness in somebody, that because we have attached a psychiatrist to you, we have attached a counselor to you, people take it as a weakness that, oh, this person is not strong enough, that's why they need to talk to him. There is that materialism that is there in our community, that I do not have to see somebody. But as regards, yes, there is that psychosocial support that needs to be given, and we are offering it to health workers. At least I've seen it, and as much as possible, we have said if a health worker has a problem, please do talk to this welfare person, and the person can be able to support. Surrounded by family, he's surrounded by people around them, and now a part important issue that we are actually dealing with as government.
Okay.
Part of the problem, I think, in this particular situation, and Doctor has put it, and we I think is the issue of attitude, because the attitude of the population, the community, but also those who are sick, even the health workers. I participated in the National Immunization Days. It was a program meant for stepping up immunization among the below 5 in response to polio and other diseases. But you because of information, you do go to this village and you find the children have been locked up in a house because of, again, misinformation. But I think this issue of misinformation, especially in the health sector, has been here for long. And like Akol put it, I think we now need to see more of a similar campaign, which may be non-medical, but in terms of community mobilization, so that the people of Uganda know that it is to be healthy, you can get treatment, but sometimes you don't need a doctor to attend to you. You can be a doctor of yourself, because we have seen not only actually COVID, but the practice and we're talking about the bigger Africa, that people of this, some of them have even turned out to be more dangerous than the COVID itself. So I think there is also a need for the ministry and for government and for the health population to ensure that in the future we have a specific commitment to the mobilization through information, so that the people of Uganda and Africa generally have the information.
Dr. Msoke, our time is running out. Our parting shots, respond to these two issues before you sign out, and we'll let you go do work. It's very early. You actually need to have breakfast. First and foremost, we have lost about 30 or 40 health workers in this country, our frontline workers who have also succumbed to this deadly COVID virus. I don't know what the situation is in Sierra Leone, especially the fatalities on the health workers. And secondly, how are you managing home-based care, if at all you also have it in Sierra Leone, as we part ways?
Is he muted?
Did you mute, Dr. Msoke, did you mute your audio? Have you muted your audio?
Sorry, I was actually muted.
Okay. Okay,
Right.
come on.
Yeah, sorry. Yeah, before I get what you have asked me, to have an input into the possibilities of working from home, just to observe that in some of the jobs we do are really contact jobs, and it is difficult to avoid that human-to-human contact. I would imagine how a police would effect an arrest without physically interacting with the suspect, or a dentist checking his patient without looking into the mouth. So some of these scenarios are quite challenging, and we have to keep working around them to see how best we can protect everyone around us. Concerns about health workers dying, the same was really running through my mind. a lot of doctors and other healthcare workers, even in Uganda, have succumbed to COVID-19, which is really very unfortunate. And many of them really get it in the line of duty, which again is unfortunate and a clear example of the gravity of the problem that we are dealing with. So in Sierra Leone, health workers have not been spared, really. We have seen also health workers getting COVID-19, and right from the start of the pandemic, we have been recording them, and I don't have the exact statistics at this point in time, but I'm cross-checking.
Okay.
Yeah, currently we have so far got about 251 health care workers confirmed to have got the infection. But the number of deaths, I don't have them at this point in time.
Okay. Well, Dr. Msoke, do you also have home-based care in Sierra Leone?
Oh, yes, in fact, because of the burden at this point in time, it is only the severe cases that are being managed in the treatment centers. So the approach we have is the facilities where severe cases are managed. Those are the clinical care centers. We also have community care isolate. Then that is also encouraged. But it is something that has to be assessed by the team to ensure that the circumstances around this individual allow for self-isolation to take place.
Dr. Msoke, we want to very much thank you so much for being with us and for having endured and allowed to be with us on our Pan-African Friday here live on UBC TV, back home in Uganda. Thank you, Doctor.
Thank you so much.
Very welcome. Thank you so much. Dr. Msoke is an epidemiologist working in Sierra Leone, and of course also trying to manage it from the side. Our time has actually run out. Gentlemen, Dr. Yen, your final clarion call to the public just before we get out of studios, and again prepare for the minister's pressure this afternoon.
Yeah, it is not an individual who is going to let us go through it. It is us, a community who working together are going to go through this pandemic. So again, there's going to be a lot of information outside there. We are going to go through, so now the information that is outside there, do not feel ashamed asking your friend, do not feel ashamed getting through the various media to be able to ask. But again, lastly, when you look at COVID again, the human being is a vector. It is through the human being that will be able to transmit to a fellow human being. So the answer is with us. And the answer that we say is with us is that it is only through the protection that we say, put on your mask, physical distance, and once you do that, then we'll be able to, but lastly, please do vaccinate. Please do vaccinate. There are no magnets in that vaccine. The people who are putting kids on their arms,
electrolysis, lots of things happening.
Yes, there are no magnets in that vaccine, and that vaccine actually does work. I myself have taken the vaccine. Many people have taken the vaccine, and the vaccine does work. Let us take that vaccine. That is going to be one of our ways for us, as we say in quotes, to see how we can come back to living a close to normal life.
Okay. Gentlemen, our time is up.
Yeah.
A call.
Yes, I can say that our hope as a continent rests in the doctors and pharmacists. So they should work around the clock, surely, so that they should sustain our hope. Yeah.
Okay. And Ndugum Twitter?
And exactly, we now, people need to listen. I like Dr. Msoke when he said, first take the vaccine, then ask questions later. And of course, to obvious, I think all of us here have taken our vaccines. Seriously, let's observe the SOPs, because it's for our own benefit.
Well, I want to thank you so much, fellow panelists of the Pan-African Friday, and of course thank our guests today, Dr. Yen Okello from the Dr. Robert Musoke Ntate, an epidemiologist now in Sierra Leone, for also having joined us from Sierra Leone live on Zoom, and we thank you so much for your thoughts. We only want to wish you all the best. It's 11 o'clock in Kampala, and we know that it's possibly maybe just 8 o'clock in the morning in Sierra Leone. So we need to let you, Dr. Musoke, enjoy your cup of coffee this morning if you're not fasting.
I'm not fasting. In fact, I'm going to have coffee very soon.
Well, we want to...
Thank you so much for the opportunity to host me.
Okay, thank you very much, Dr. Robert Musoke Ntate, right there in Sierra Leone. My name is Jagenda Semakola Ziksoka, and of course thanking the team that has put up this program this morning, the producer, and of course all the backroom staff. We thank you so much, and to just let you know that today at about 1 o'clock, the minister will also be addressing the nation on what next we need to do, live here on UBC TV. I am Jagenda Semakola Ziksoka. Good morning and bye-bye.
Live from UBC Studios in Kampala. Good Morning Uganda Extra.
Makes learning easy.
The strides made in our field could not be possible without it.
And now we can watch our favorite show.
My radio is my best friend.
UCC provides an enabling regulatory environment and policy guidance for healthy competition. We also facilitate ease of doing business in the communications sector through licensing, standardization, spectrum management, tariff regulation, rural communication development, and consumer empowerment. An informed consumer is an empowered consumer. UCC supports local content and innovations, driving the development of a robust